Hi, everyone. My name is David Ansell, and I'm an internal medicine physician and the Chief Equity Officer at Rush University Medical Center in Chicago. And I'm going to be speaking today to you about my topic, Beyond Diversity, Equity, and Inclusion, a strategic approach to addressing systemic racism in healthcare. Just a little bit about my background. I've been a physician in Chicago for over 40 years, still practice primary care medicine on the west side of Chicago. I'm a son of immigrants, and my parents' families in Europe were wiped out in the Holocaust. And I grew up in this country during the civil rights movement, and I couldn't help but to be aware of the parallels between my family's history in Europe with the Nazis and what was going on in this country. That led me to medicine, and that medicine career led me to come to Chicago because I was really interested in taking care of those who've been marginalized. My career took me from Chicago's Cook County Hospital to Mount Sinai Hospital in Chicago to Rush University Medical Center, an academic medical center, where I arrived about 15 years ago as the inaugural chief medical officer. But I couldn't help but think that the experience that I had and my patients had in Chicago's safety nets were very different than the experience at a place like Rush, an experience I call one street, two worlds, because along one Chicago street, I practiced for 40 plus years, and they're very, very different experiences. And it made me think more about root causes, which we'll talk about a little bit, and led me to move into a new role at Rush, which has been around for the past 5 years as the Chief Equity Officer, really focusing on how can we address the social and structural determinants of health. So this slide here is just a picture of Chicago from the point of view of West Side residents. And you can see the verdant green west side of Chicago with multiple different neighborhoods. And you can see the life expectancy of these different neighborhoods here. But my talk is going to focus on our work and probably our national work as we move ahead. So 3 learning objectives for today. Number 1, COVID and Black Lives Matter and the reason why we need to have health system equity strategies. I'm going to talk about the Rush evolving equity strategy, and it is an evolution, even though we've been at it for 5 years. And I'm going to talk about an entity that we helped create called Westside United and the Chicago Racial Equity Rapid Response Team, which was formed in Chicago in response to COVID. But let me start with the moment that we're in. So we had the COVID virus named the Great Equalizer when it first came to our shores. But as we learned early in the pandemic, it wasn't the Great Equalizer. It disproportionately killed Black people. And then Latinx people as well, Native Americans, other marginalized populations. And then we had the police killings of Black people, again, the most shocking types of deaths, repetitive deaths that have not been reduced even during a pandemic. But it was actually George Floyd's murder that we all witnessed on TV with his killer on his neck and George Floyd narrating his own lynching. That actually brought racial inequality and its disproportionality into full view. I will say, if I had a third picture on here, I might have on it Donald Trump's a president's executive order saying that teaching anti-racism is actually racist and un-American. So we're living in a time of great conflict where issues of equity and justice have come to the fore, but also a time in which white supremacism has reared its ugly face once again. So the question for all of us, particularly in healthcare, but not just in healthcare, is how do we change the narrative? How can we reframe the moment we're in a way that we can all do better? So this is a poster from World War II. And I show this just to make the point that all of our health systems were built on a foundation of white supremacism. In America, segregation, separate facilities for Black and white people, scientific racism, the exclusion of Black doctors from the AMA, scientific racism, the Tuskegee experiment, and many other experiments are the foundation on which American healthcare was built. Here's a poster from World War II making the case that the blood supply between whites and Black people was identical. There was a time in this country where there were white blood banks and Black blood banks. In fact, the science that was applied to try to explain racial differences, to keep Black people subjugated as an underclass in this country, were the exact same processes and procedures that the Nazis adopted after coming to America to promote their racial hatred. I say this because all of our institutions have this legacy, and we could all, if we dug into the history of our institutions, find actually how it actually worked on our institutions. But that was then. In the early 2000s, the Institute of Medicine, now the National Academy of Sciences, put together a compilation called Unequal Treatment that showed that Black outcomes were different than white outcomes across almost every category of health outcome that you could identify. And they made a bunch of suggestions in that book. And then our national policy on the right is the healthy people from the Health and Human Services and such, that the goal in 2010 was by 2020 to eliminate health disparities. Actually, the goal was to eliminate them by 2010 in this country. And you can see, despite all of the advances in healthcare, we've not even become close to eliminating health disparities. In fact, if you add up from 1900, all the excess Black deaths in America that have occurred simply because Black people have not had the same life expectancy outcomes as white people, that would be 8.5 million excess Black deaths. So this is, a historical legacy pointed out many, many times over decades, even centuries. The first major study on Black, white health gaps was done by W.E.B. Du Bois, the first Black man in the United States to get a doctorate from Harvard. And he pointed out the difference in health outcomes in Blacks and whites in Philadelphia, and attributed in turn of the century, around 1900, that social conditions and racism were the cause of these health outcomes. That was then, and this is now. So there's been this great imbalance. I think the Black Lives Matter movement and COVID disproportionately has brought this back to the attention of our health systems in particular. We are founded on principles of social justice. Our jobs every day is to take care of patients the best we can. We oftentimes are the first ones facing those who've been marginalized, the conditions under which they live, and we can't just treat the disease if we're not taking into account where people work, live, and play. And so this is very central to our work, and yet healthcare has often failed to both either grasp the enormity of the situation or put our arms completely around a way of thinking about solutions. I was the inaugural chief medical officer at Rush, coming here in 2005, but understanding the nature of the problem, I moved into this chief health equity officer role in 2015. And did this because we were changing our mission, as many health systems did, from being the best in healthcare to improving health. And I helped lead with many colleagues at Rush our community health needs assessment that I know many of you have to do. And what I'm going to show you right now summarizes our presentation to our board of directors that launched us into a new approach to health and health equity. And this is a map of the L tracks in Chicago. It's really just focusing here on the west side of Chicago. You can see the lake over on the right-hand side in blue, beautiful Lake Michigan. And you can see life expectancy along the L track. And if you live in the loop, you can live to be 85 years old. And if the loop were a country, that would be equivalent to being first in the world in life expectancy. But you go 7 stops down the blue line, 3 stops past my hospital, and you gradually see life expectancy plummet to under 69 in Garfield Park. And if you ask yourself, when was the last time in US history that life expectancy was under 69 years old, you'd have to go all the way back to the 1950s. So 7 stops, 7 decades of life expectancy. And when we showed this to our board, we asked the question, why? Now, I will point out that the loop is almost 100% white. And Garfield Park is a neighborhood of concentrated poverty that's almost 100% Black. So we asked the question, what's the reason for this life expectancy gap? And we told this fact that a 16-year-old Black teenager who lives in Garfield Park has about a 50-50 chance, a little better than a 50-50 chance, of living to the age of 65. And we asked the question, what's the cause of death? And when we asked this question, a hand would raise in the audience, and the answer would be violence. Because oftentimes Chicago or the west side of Chicago is associated with gun violence. But in reality, more than 50% of the premature mortality, these are deaths before the age of 65, are from cardiometabolic disease, heart disease, and cancer, diseases for which we have early detection and treatment. And so it's the common chronic diseases that account for the biggest gap in life expectancy between Garfield Park and the Loop. And it's at this point in time that I talk about this idea of structural violence. Structural violence is structural because it's designed into our laws, our policies, our procedures, even our norms, the way we school, the way we house, the way we police, the way we, how jobs are organized. and it's violent because people die as a result. And so I talk about structural racism as being a form of structural violence because it kills people early. And it's a way of actually reframing how we think about disease causation. And we're going to get back to this over and over again. In medical school, I learned that the causes of disease were tied to what I call the 3 Bs: beliefs, behaviors, and biology. And it's not to minimize any of these as being important parts of this, but as you all know in this audience, 80% of what causes poor health is not biology, 80 or 85%, or it's not beliefs, and that social conditions and structural conditions, things like structural racism, things like economic deprivation, lie at the root cause of poor health. So I didn't learn that in medical school. I learned this from being a practicing doctor on the west side of Chicago. And I brought that thinking with others to our organizational leadership as we began to think about how do you really begin to improve health. If that's our mission, what is it that we need to do? So this is not an issue of just Chicago. Where you live dictates when you die all across America, including all across the world. And I like to show this slide because it shows you really how income is a big driver of life expectancy. So poverty and who gets assigned to poverty in the United States has everything to do with who lives and who dies. But where you live can make a big difference. So you can see that there's when you get to median household income, the life expectancy curves across New York, San Francisco, Dallas, and Detroit are exactly the same. But when you get below median income, you can see that if you live in one city versus another, and this is true of rural America as well, your chances of living are very, very different. But if you're in the top 5% of income, all the way over on the right-hand side of the slide, it doesn't matter where you live. And this is true, again, not just the fact of Chicago. This is has to do with who is assigned to live in neighborhoods of concentrated poverty. And what are your policies and procedures and your regional policies and procedures that can make a difference? So this slide just really says public policy makes a difference. In telling the story within our own organization and retelling the narrative, I have a little framework for which I think of leadership and leadership change around anything, but particularly around health equity. Narrative plus data plus action equals change. So it was important for us not to show just the life expectancy gaps in the neighborhoods, but to show how our own patients were faring. And so we lined our patients up along the same L map. And what we found is that if you lived in West Garfield Park, the cost of care for diabetes was about 3 times as high as if you lived near the Loop in Chicago. And so we could say from a population health perspective, if we were going to do better with taking care of these patients of ours, and these were patients who had both hypertension and diabetes. These patients were matched on everything except for neighborhood. So if we're really going to make a difference in population health, we have to address neighborhood conditions in a more thoughtful, deep way. But then to really bring it home, we looked at our employees. So one of the things we did is we named 10 West Side communities as our key community areas. These neighborhoods have about 600,000 people, and they're about 40% Black, 40% Latinx, and 20% white, reflecting the great diversity of the city of Chicago. But we lined our employees up along the L track, and we looked at their financial hardship. And those employees who lived in the lowest life expectancy neighborhood, 1 out of 5 experienced financial hardship. We got these data from our Treasury. This is work that you can do within your own institutions. And if you lived in a wealthier neighborhood, say the near west side of Chicago, only 4% had financial hardship. And if you lived in the Loop, it was about 1%. So 18 times the financial hardship for our same employees who lived in the lowest life expectancy neighborhood versus the highest life expectancy neighborhood. There was a method to this madness. We all view ourselves as healing organizations and great places to work. But one of the things we recognized was that our employees, especially our low-wage employees, could come to work at our institution, serve our patients day in and day out, and retire 30 years, 35 years later in poverty. And that was never our intention. It's always different as well when you point out that the person who empties the garbage, or the transporter, I like to say Hank the transporter, who all of us know might be suffering hardship, and that's someone we know, versus just showing life expectancy in the neighborhood. But we think this idea of lining up neighborhoods with patients and employees is a great way to bring this idea of health inequity home. It's critically important to name root causes. I'm, as a former chief medical officer, when we're dealing with patient safety or quality in the hospital, and you have an adverse event where a patient comes in the hospital and harm occurs inadvertently in the hospital, you always have to do a root cause analysis. And it's really important to do a root cause analysis because if you don't get to the root cause, another patient could be harmed down the road. And that's a precept of patient safety. And of course, for those of you who study patient's experience, that's true as well. When you find a driver of poor patient experience, it's important to look at those drivers. So it's really important to name the drivers of poor life expectancy in America explicitly. And so on the west side of Chicago, in our neighborhoods, we named one of the drivers of low life expectancy as being racism and economic deprivation. And for the first time in our community health needs assessment, first time in a report that Rush put out in its 180 years of existence, racism was named as a root cause. Now, I never learned in medical school that racism was a root cause of poor health, or that economic deprivation, poverty was a root cause of poor health. But it's critically important that we name them, because then we have to address our efforts at solving those root causes, either through direct action or through our ways of influencing public policy. And if you as an organization, as an organizational leader, have not begun this journey of naming social and structural root causes of poor health, I really encourage you to begin to think about it and talk about it. It's critically important. And this is very, very, very different. And when you get right down to it, the reasons for poor health outcomes have to do with the fact that in these neighborhoods, people do not have access to the same resources, money, and power that people in other neighborhoods have access to. And these are not acts of accident. These are not acts of poor behavior or poor attitudes or anything else like that. I call these acts of affliction or acts of oppression. Who's poor in a country and who gets to experience opportunities to achieve middle-class status or wealth are matters of political policy and economic policy. So just as we talk about social needs and social determinants of health, so are there political and economic determinants of health. But it's critically important to name these root causes. So I want to talk to you about thinking about equity as a strategy. Now, I will also say to you, if you really want to learn about some of our tactics, our specific programmatic things, please reach out to me via email david_ansell@rush.edu, because I will be happy to share. I'm going to just stay high level now and just talk to you about what does it mean to make equity a strategy. So first, it's an inside-outside strategy. So you can't just build a community-focused strategy without thinking about what are you doing inside your own organization. When I talk about inside your organization, it really has to do with all aspects of the healthcare organization or system. So number one, equity strategy is best put in place if it's endorsed by your trustees and led by a senior leader. I was one of the first chief equity officers in the country. Now, and more systems are doing it. Is your system doing it? Because without this focus as a senior leader position, it's hard to get it done. Our own plans call for us to accelerate diversity and inclusion in leadership. And our aim is to achieve demographic parity in leadership. Are we close? No. Do we have this as a goal? Yes. And since the Black Lives Matter movement, we are doubling down on these efforts at Rush, and we formed a Racial Action Justice Committee to really accelerate our leadership representation, but also the climate in our organization that makes it hard sometimes for people to advance. We screen our patients for the social and structural determinants of health. We've been doing this for a few years now in our primary care, in our ED, in our inpatients. We're trying to get this to scale, and we find this is critically important, not only to address social needs, which are very high. We're finding food insecurity, housing, and even access to primary care, major gaps, but also to address then in a coordinated way neighborhood conditions. As I mentioned before, we named the root cause of health inequity, including structural racism, economic and educational deprivation, and we really work to get our leaders more comfortable speaking these terms and saying them. And I can tell you, over the years, people are getting much more comfortable talking about that, despite the fact that we're fighting ideas in this country about whether or not structural racism really exists. We say yes, it does, and it's critical for healthcare leaders to talk about it. We've identified many opportunities to build wealth among our low-wage employees through pension reform, educational and career pathways, and we've seen a reduction in employee financial distress, and are really thinking of new ways of doing this. We've raised our base entry-level wages to $15 an hour. We've started career paths, as I mentioned, and a lot of financial wellness programs, but a lot more to do in this arena. We adopted the anchor mission to buy, hire, invest, and volunteer locally. We've integrated health equity measures in our quality plan that goes all the way up to our board. We have identified healthcare outcome gaps. We have specific projects right now around cardiometabolic disease, as well as maternal infant health. But the critical piece of this is one has to call out equity in your performance improvement plans, gather the data in a way by race, ethnicity, and language, as well as sexual orientation and gender identification, but you can do it by income and other measures of poverty, and identify where you have gaps and eliminate them. Most healthcare systems in the country, despite those reports from the early 2000s, are not looking at their data by race, ethnicity, language, gender, and age. We partner with community groups, hospitals, community providers to address place-based root causes of these gaps. And we communicate in many forums about what we mean by the words equity and racism. You know, a lot of people put the word equity up there, but they don't have a good definition. We talk about equity as those who need more should get more. We talk about thinking about our policies and procedures and asking what does it mean to have equitable policies and procedures. We are not there yet. This is a work in progress, but over the last 5 years, we've made great strides. And we're hoping through our new Racial Justice Action Committee, we're going to be able to coach and teach leaders who do not understand this how to get better at this work. So as I said, it's a work in progress, but this is our approach to this. When we decided to change our mission to improve health, and we adopted the anchor mission, and we created a framework for health equity within Rush, we decided that was not enough. There was no way that one healthcare institution could take on the health outcomes of the West Side of Chicago, and we needed help. Historically, Rush has always been a very high quality healthcare institutions. We're ranked #1 in Vizient in quality. We have really good patient experience scores. We're a very, very good clinical place and have been known as that. But we were not known very well in the community, even though we had a number of community programs. One of the things we had to do is we had to reflect on these community programs and ask ourselves what makes a healthy community. And when we did that, we realized we had many programs, but they were not designed to move the dial. It created a great experience for a medical student or maybe for a faculty member, and not to say people weren't helped. But we began to dig deeply into programs that we were involved with that made a difference. And we found that they all had similar characteristics. They were multi-partner organizations. They had many, many different stakeholders. They were oftentimes intersectional, meaning people from different sectors. They had measurement associated with them, not just output measurements, but outcome measurements. And when we identified those programs, we said, we need to be involved. If we're going to have an impact on life expectancy in our neighborhoods, if we're really going to take on the social and structural determinants of health, this is going to have to be more than just one organization like Rush. So we went around to the other hospitals on the west side of Chicago and asked them if they would help convene with us a community meeting so we could talk to them about our ideas about improving health. And we did that, and in 2017, University of Illinois, Chicago, the health campus here, Cook County Health, the public hospital, and Rush convened a meeting on the west side of Chicago with community leaders, showing them that life expectancy map and asked the question, what if we all came together in a partnership around this? And what if we, in a partnership with community, could begin to address the social and structural determinants of health? What do you think about that idea? Well, we got a number of pieces of feedback. One was, well, where have you been all our lives? Two was mistrust. But the third one was, we think that if you really came to us in this way, we really want to participate. And that led us to create an entity which was launched in 2018, named Westside United. And you can look this up. There's a website, www.westsideunited.org. And you can see our webpage and our metrics. We launched in March of 2018. It was launched as a racial health equity collaborative. And we had to get all the hospitals on board with naming this as a racial health equity collaborative. And our leadership group is 6 hospitals partnered with 6 community leaders who are paid to be on the board. There's a community advisory council of 18 community leaders also paid to participate. And we've identified 4 major domains of our work, our pillars: health and healthcare, economic vitality, the neighborhood and physical environment, and educational achievement, with the idea to holistically address the social and structural determinants of health, including structural racism. We name it. We say its name over and over again to get people comfortable with this. Have a unified Westside voice to outside audiences, create opportunities to scale programs that work and support community-based programs that are being successful right now, and create common measures of success. Now, once we got people on board with this, we've been multiple meetings now over the last few years on many, many domains. There are a number of subcommittees. For example, we have the Westside Anchor Committee, which has about 9 healthcare organizations around the table, building out what it means to be a healthcare anchor. So there's many meetings. We have a subgroup called Live Healthy Westside that's bringing all the providers on the West Side together, including the hospitals and the FQHCs, around cardiometabolic health measures, as well as maternal and infant health. So a lot of activity around this. But this is the largest grouping of anchor healthcare institutions in one region in the country, and therefore likely the world. But I gotta say, it's been eminently successful. And it's been eminently successful because we all can take credit for the work that's being done. All the institutions are able to take credit. And it's doing work that not one of us could do on our own. Here are the institutions that are involved: Amita Health, Ann and Robert Lurie Children's Hospital, Cook County Health, Norwegian, American Hospital, Rush, Sinai, UI Health, West Suburban Medical Center. If you would to look at us, we would be the largest corporation in the state of Illinois, with an incredible number of annual hires, purchasing, employees, etc. And we really have the opportunity collectively, as I mentioned before, to change the narrative of what health means in the city of Chicago. We're focused on 4 impact areas I mentioned before to address the life expectancy gap. And we want to eliminate health disparities by incubating and scaling these prioritized interventions, enrich the vibrancy of the West Side by investing in people and local businesses, capital investment in the neighborhoods and addressing the infrastructure. For example, we have a project on food gap between the north side of Chicago and the west side, involving many, many different institutions. And we have work around educational outcomes, very, very specific intersectional work linked to Chicago schools. But our big aim, our meaningful, actionable, specific, time-limited goal, a mass goal, is to reduce the life expectancy between the Loop and the West Side by 50% by 2030. And when we raise this as an aim, some of our colleagues said, we can't say that. How can we do that? But we explained to say less would be doing an injustice to our community. Can we do it? We think it's possible. It's a stretch goal, but we've named what we're trying to do, which is to eliminate a death gap. And by doing so, we're addressing the 5 major drivers of life expectancy, which I mentioned before. People think it's just violence, and it's not just violence. Number one is cardiometabolic disease. Number one is two is cancer, and three is homicide, infant mortality, and the opioid overdose epidemic. By focusing on the social determinants of health within our impact area, and then measuring. We have a lot of measures to this work. I want to just sort of flip now to COVID and what happened. Obviously, COVID has been disruptive to all of us. And when in early April, we found out of the first 100 deaths from COVID in Chicago, 70 were in African Americans. The mayor got on national TV and just said, this is outrageous. It's just not shocking and outrageous, but we have to do something about it. And the mayor talked to her team and asked them to give me ideas of what we can do. And her team gave some ideas, and she said, that's not good enough, call Westside United. So on a Sunday night in early April, we got on the phone with the mayor's office, and we suggested that collectively we create kind of a SWAT team to address the immediate impacts of the pandemic while addressing the longer term impact. And we suggested that the SWAT team, which has become called Chicago's Racial Equity Rapid Response Team, that this be modeled like Westside United, with the providers and community groups sharing power and decision-making around the table with the mayor's office. And the next day, the mayor held a press conference announcing the Racial Equity Rapid Response Team and naming Westside United as a co-convener of it with the city of Chicago. And it was part of the emergency response to COVID and gave access both to the hospitals and the communities to the mayor's office. In this picture here, you see one of the early things we heard from our communities is people are hungry. So while we needed to address the COVID response, and we did around testing, around other things, we also organized food, and we've organized the direction of multi-million dollars in grants that have come to Chicago to community-based organizations that are on the ground, that know what's happening, and can deliver to the needs of the community. We've delivered over 750,000 masks across the communities. We flipped the paradigm on patient care. There's a provider subcommittee that I co-chair that has the hospitals and all the FQHCs partner with community-based organizations talking about what to do. And one of the things we did was call our patients. So as the pandemic went through Black and brown neighborhoods, we began to call our Black and brown patients to check in on them to see how they were doing. And over 75,000 families were called through this organized process around the city. We also coordinated testing and mobile testing in Black and brown neighborhoods. So it's been a very, very effective organization. Again, complex because it has multiple partners, but modeled on Westside United and using Westside United's leadership to do this. And on reflection of this work, it really validated going back 2 years to the formation of Westside United to say this was exactly the kind of organizational structure across organization that was necessary if we're going to improve health in the city. We have a lot to do. 200,000 Black and brown Chicagoans have lost jobs. But the mission of Westside United to hire locally and create career paths for people in healthcare, to purchase locally and support businesses off of our supply chain, to invest locally into neighborhoods and into the social determinants of health was exactly the kind of work that was necessary to do now more than ever. But I want to take this next step and say, when we saw the murders of George Floyd, it was another call for action. And in our own institutions, we began to name Black Lives Matter. I want to say it was not without controversy that we did this, but we put this on our billboard as a statement of fact. And again, as I mentioned, launched inside a racial justice action committee, because institutional racism lives in all of our institutions, and it's up to all of us to begin to dig deep to see if we can make it better. But the other thing that we did is put out a public statement. And this is the public statement. It was published in the Chicago Tribune and the Chicago Sun-Times on Juneteenth this year. And its headlines is "Undeniable Racism is a Public Health Crisis." And as members and leaders from many Chicago healthcare organizations addressing the disproportionate Black and Brown mortality from the COVID-19 pandemic, we say without hesitation that Black Lives Matter. This declaration was one of the first in the country. It was much stronger than any of us would have done on our own, even a month earlier. And not only is it a statement, there's a series of commitments. And you can look the statement up. This isn't all of it. We made 7 commitments to end institutional racism in Chicago institutions. This has now been adopted by the Healthcare Anchor Network nationally. A group of 35 institutions have signed on to that. But even more than that, through this Racial Justice Action Committee at Rush, and through the Racial Equity Rapid Response program at the city and Westside United, we're coming up with an equity scorecard to measure, like the Human Rights Report measures LGBTQ health and rights within healthcare. We are coming up with what we think will be the first equity dashboard or scorecard in the country. I'm going to now wrap this up and just to talk about leadership in this frame. This is a picture, I got it from the New York Times. On the left is Bob Cousy, Irish-American captain of the Boston Celtics, and Bill Russell, one of the most dynamic duos in American basketball. And the Celtics have won more championships and consecutive championships than any other team in America. And Bill Russell really brought to the team a kind of talent that was needed to propel that team to championships. But when he went into stadiums, he was called all kinds of nasty racial epithets, and people broke into his home and left human excrement on his bed. And Bob Cousy and the other white players didn't say anything. And Bob Cousy was interviewed last year in the New York Times, because they're both well in their 80s now. And he said something that really struck home to me about white leadership in this moment. How we as white leaders in healthcare have to hold ourselves accountable to be the change that is necessary, particularly in dismantling racism and other forms of oppression. And this is what Bob Cousy said: "I wish I had done more. I wish I had done more." For all of us here today at this conference, living in these unprecedented times, the work that we have to do of ending racism, white supremacism, and the disparate inequities in health outcomes that it drives is our work. It's our leadership. It's our voices. It's our institutions that can make the difference. Let us not look back 1 year from now, 5 years from now, 10 years from now. Let's not wait till we're all 80 years old. I'm pretty close to that right now, and say, "I wish I had done more." I'm going to end on this. When we started Westside United, we did listening tours along the west side of Chicago. And we had to do listening tours because we didn't think that we could break through the mistrust unless we heard what the community said. And the community said things to us that we want what everyone wants. We want jobs for our kids. We want you to support local businesses. We want our children not to have hopelessness in their lives. And we asked our community leaders, who we pay to provide us a roadmap for Westside United, if we're successful, what would the future look like? So this is a complicated picture in that it has a bridge going into the future. And on the left, you can see the storm clouds of systemic racism, of disinvestment, of short-term focus, raining down, and it's even the person with the umbrella on the bridge. And you can see all these people working under this umbrella of Westside United, all the neighborhoods together. And down at the bottom, you see the pillars: long-term investment, equal opportunity, sustainment, advocacy, policy. And you can see the 4 squares of Westside United, the pillars in the middle, and people working to build this bridge over these historical storm clouds. But what I like the best is we ask people to say, what will the headlines say in 2030 in the Chicago Tribune? Unemployment rates at an all-time low on the West Side. West Side schools earn record recognition. And on the far right, the life expectancy of the West Side rises to match the loop. And what we like the best is changing the West Side story from violence to victory. You remember I started with narrative, and I said narrative plus data plus action equals change. Let us all join in and change the narrative. We do not have to live a tragic narrative, the narrative of the past, but we have to do it together. Thank you very much, and I'm so pleased to be here today.